Thanks for inviting me to speak here. And Christine first asked me to speak and asked me to speak maybe something about acupuncture because she knew I did a lot of acupuncture. So something like, she said, well, like what's new in acupuncture? Well, unfortunately, there's nothing new in acupuncture in the last 2,500 years, and so had to come up with a different topic. Why don't we talk about non-drug therapies as first-line treatment for pain? I spent some time thinking about this, and I've been practicing for over 25 years now, 20 years mainly dealing with pain. And I thought I'd draw on all my experiences to try and give you a framework on how to think about pain in a different way maybe than you're used to thinking about, and how to develop a framework for integrating non-drug therapies into a standard treatment for pain. And so my objective then today is I want you folks to envision with me a kind of evidence-based framework for integrating non-drug treatments for pain in a patient-centered model. And when I mean patient-centered model, I mean patient-centered model. I mean we have to really kind of figure out what is it that our patients want or need, and how can we partner with them to deliver what they need for pain, rather than just assume we know what they need, because sometimes we assume a lot. I'm going to put it to you this way, is that how we decide how we treat our patients, whether that's with drugs or non-drug therapies, is often a cultural issue. And you might not have heard it described that way, but really there's two ways to treat pain. One is a kind of anti-nociceptive paradigm, right, where we use drugs and nerve blocks, and we kind of block pain as it's going up there. So, but sort of left-sided approach. But there's an equally, I'll put it to you, an equally effective way, and maybe in some cases for a chronic pain model, more effective way to battle pain is to increase the activity of descending pain inhibitory pathways. And then we can see on the right side. And so how we decide whether we use a non-drug or a drug approach, I think, is basically a matter of culture. Is we do what's always been done, or we do what our colleagues do. It's not a really kind of a scientific way, I think, sometimes. And so what I'm going to try to do is give you maybe a more evidence-based approach to that. So the way I'm going to term things is that there's two ways to approach pain, and they're complementary, meaning they could be additive and work together. So there's a bottom-up approach, which I'll call an anti-nociceptive approach, which are drugs and anesthetic blocks, and there's a top-down approach, which is an activation of descending pain inhibitory pathway approach. And I think that's mainly non-drug treatments, but also treatments with certain antidepressants that we know have effects on pain, the tricyclic antidepressants and SNRI. Kind of a culture that we're not maybe always sure why we're in that culture, but there's a bottom-up culture. And in bottom-up culture, there's a kind of idea that pharmacological treatment is always first line, and pain intensity should dictate pain treatment. And so the way we should treat pain is to measure pain intensity and then go from there. But there is another way of looking at things. That's what I'm going to talk about. And we sometimes in the anti-nociceptive culture or bottom-up culture, we see the statement that, I've seen this a few times, a statement that non-pharmacological treatments should not substitute for adequate pharmacological treatment. Now, I've seen that statement in a couple of pain management guidelines, and I could trace it all the way back to 2002 Registered Nurses of Ontario Association Guides for the Management and Assessment of Pain. Now, I think that's an opinion. I'm going to put it to you that's probably true the other way around, is actually that pharmacological treatments should not substitute for adequate multimodal pharmacological and non-pharmacological treatments for chronic pain. And that's a kind of maybe more scientific viewpoint. I think that's a cultural bias in some ways, and we're going to talk more about that. The other kind of thing that's a cultural viewpoint is that multimodal treatment always means multimodal drug treatment. I think in the chronic pain world, multimodal treatment means multimodal drug and non-drug treatment. So the point I'm trying to make is we often decide for our patients what we think they should have. So why is it that we often prescribe drugs and block type treatments for patients? Because patients, it's known, often prefer non-drug options. And there's a great deal of literature on this subject, and I like this little snippet from an article back to 1984, but I like it because it's succinct. And they say, well, they asked, well, why do patients prefer non-drug options? And they looked at 4 hypothetical patient scenarios for sore throat, gastroenteritis, hypertension, and arthritis. And they said, well, patients prefer non-drug options, including home remedies and other options, because they're risk averse and they're willing to accept some discomfort. So I think that's important, because if our only goal is to reduce pain and reduce discomfort, then maybe we're not doing exactly what our patients want us to do. And their conclusion was that patients informed about the risks and benefits of drug and non-drug therapies will prefer the latter if that option is offered. So I want to ask the question is, do we offer non-drug options in a scientific way to patients? And I know when I research the subject and how it's kind of taught locally and presented locally, we all offer non-drug options, or we mention them, but we mention them as kind of a sidebar and at the bottom of the page, and you could also, and it's not a real kind of there's not a real framework for how we address that. We know we should address it, and we do address it, but it's kind of like an asterisk often. The way I see it locally anyways, my experience has been that we offer drug therapies or non-drug therapies. We only seriously consider them when the patient requests them specifically, or we assume they want them. And so we sometimes use a kind of a screening tool, formally or informally. I'm talking about the Birkenstock screening exam. Do you guys know that one? Well, I'm sure some of you use it. So if the patient's wearing Birkenstocks is one point. Purple socks is another, and wire rim glasses is number 3. And so if the patient scores 2 or more, then we have to talk non-drug therapies with them. And so today I'd like to go beyond that a little bit and make it a firmer framework. The other way we see consideration of non-drug therapies is as a last resort, when medication or surgery is not effective, it's not safe, or it's not available. And that's, I think, a real common approach. And there's reasons for that. It's not just because we don't want to offer it earlier, but there's reasons that we're going to talk about in terms of availability later. And the third situation when we consider non-drug therapies is we just don't know what to do with the patient, and in my experience that's due to when there's pain and unrecognized depression. So then when do we want to consider non-drug therapies as first-line therapy? Well, I'm going to put it to you this way. I'm going to give you a framework, and the framework goes like this. If we only consider analgesia as our goal, that's the goal we've determined with our patient, that's our only goal, then we don't have to have this talk, and we don't have to talk about non-drug therapies, because drugs do a great job for analgesia. But when we talk about other treatment goals, other reasons why we want to treat pain beyond analgesia, then we think of other things and scenarios where non-drug therapies are important. So when we talk about maintenance of function, we have to look at non-drug therapies. You've probably never heard it talked about in a pain talk about preservation of higher consciousness, and that's a consideration sometimes, especially at end of life, and it's important. I'm going to talk about that a lot. Do we ever ask people? No. Is it important? It's very important to some people. We should consider that. And how do we consider that? We don't assume that it's important or not important. We have to make a team approach with our patients. Another consideration I want to put forward to you, something that's been getting a lot of press lately, is the issue of suicide with chronic pain patients and suicide with medications that have been prescribed for treatment of pain, and accidental death through pain medications. Should that be a concern when we're considering treatments and we present those treatments to patients? I think absolutely. Would non-drug therapies be important if our concerns were prevention of suicide or accidental death? Absolutely. And the patient's request and what the patient wants, if they're risk averse and their main reason for having their pain treatment is to maintain quality of life, that's different than just analgesia. And there may be other specific patient preferences that we want to ask about when we form a contract with our patient, a therapeutic contract. And so in preparing this talk, I didn't use marginal information sources like the Journal of Couch and Sweaters and Self-Roll Cigarettes. Didn't do anything like that. But I looked at what I think is sites of good evidence, and one was the National Center of Complementary and Alternative Medicine that has a website, and the NCCAM is a division of the National Institutes of Health. Okay, so a reputable organization. The other one I looked at, and we're going to look at together, is a Society for Integrative Oncology. We're going to talk about them. And also the Cochrane Collaboration. The Cochrane Collaboration is a supposedly unbiased clearinghouse for information about all things medical, and not pointed one way towards drug or non-drug treatments. And the other resource I used was the American Academy of Family Practice. Pain, we're going to divide that a little bit more and talk about nociceptive and neuropathic and sympathetically mediated pain. But I'm also going to suggest to you that we add a fourth category, and you should consider pain and comorbid depression as a different category of pain, something that has to be recognized and is a different kettle of fish, gets treated differently. Have to keep our eyes and ears open to recognize that. It's a different category altogether, and we have to be aware of that because it's treated differently. So this venerable monk on June 11th, 1963, in downtown Saigon in South Vietnam, sat in the lotus position, doused himself with gasoline, and had previously invited reporters from the New York Times to film this and record the issue. And he did this to protest the treatment of Buddhists in South Vietnam by the government at that time. So he did this is a kind of premeditated act. And so he set himself on fire there, and he died. And he didn't move 1 centimeter during that whole episode. By looking at the slide, is that what was this? Was this a bottom-up treatment or a top-down treatment? Well, you don't really know because you don't know if he anesthetized himself or such, but I know he didn't. So it wasn't an anti-nociceptive pain management paradigm he used, but he used a top-down pain management paradigm. And Don was asking about mindfulness. Do you think he was mindful? And what were his goals? What were his goals of organizing his approach to pain management? Was it anti-nociception? Was it analgesia only? Or was it preservation of higher consciousness? It's different. So my point is that activation of descending pain inhibitory pathways, that paradigm can provide not just kind of fluffy pain relief for kind of splinters and paper cups, those kind of things, or kind of popsicle burns or something. It's not like that. This kind of can provide a very strong method of pain management for very strong pain. If you want to know further about the story, he made his point, actually, and the South Vietnamese government changed their policy towards Buddhist and repression of Buddhism as a result of his, I think, transcendent action. So you might say that, well, that's kind of interesting. I never heard about that before, and that's a kind of a rarefied approach to activation of descending pain inhibitory pathways. That's not practical in regular life, and we don't do that kind of thing in real medicine or real nursing or hospitals, that kind of stuff. That's interesting, but not applicable. There is one type of pain that's severe, and that we consistently use and recommend non-drug treatments as first-line therapy for a kind of severe acute pain. What is that? Childbirth. Yeah. So what is it that's specific about childbirth pain that means for that type of pain we should use non-drug therapies as first-line treatment, and other acute pains we shouldn't really consider, or consider only if someone looks a certain way or we kind of figure they might or might not or something like that? What's specific about childbirth pain that makes it amenable to non-drug therapies? Our functional goals are different than just analgesia. Exactly. It affects the baby. What else? It affects your experience with the baby, people say. So if a consciousness issue, you want to be fully conscious when your baby's born. It's interesting. But childbirth, I think, is the only aspect of pain treatment where we really kind of, it's accepted that activation of or pain inhibitory pathways and use of non-drug therapies is accepted. It's a first-line thing. We always give patients a choice. We always make that conversation up front with them. Why don't we do that in the rest of, in treatment of the rest of pain? There's no good reason, I'm going to make the point. To kind of see if there was science about this kind of thing, and I used to deliver babies some time ago, we looked at the Cochrane collaboration. They have a summary about pain management and labor. And what they say, as they always say about these type of things, is the findings are not definitive, but that won't deter us from listening to what type of things. Is the findings are not definitive, but that won't deter us from listening to what they have to say. But we found that immersion in water, relaxation, acupuncture, and massage all gave pain relief and better satisfaction with pain relief, drug treatment and blocks. And some important outcomes were rarely or never included. For example, sense of control, breastfeeding, mother and baby interaction, costs, and infant outcomes. So my point is going to be, as you see, hopefully I'm making it, is that if we just have one outcome with analgesia, then we don't have much of a discussion about non-drug therapies. But if we look at other outcomes of pain management, such as function, such as breastfeeding, then we have to look at non-drug therapies. We have to look at them seriously, and we have to recognize that they have serious effects on pain. It's not just fluffy pain. It's a kind of serious pain we can deal with in a non-drug way. And the last example we're going to talk about in terms of non-drug management of acute pain is back pain. Now, you know, Google Images is a fantastic thing. When you look up back pain, under Google Images, you see all these pictures of really muscular guys going like this, and women in bikinis and kind of holding their backs and things. And then not too many realistic depictions of people that get back pain. But I found one, and only one. And the point I want to make is, in terms of back pain, that there is very good evidence that non-drug therapies work for both acute and chronic back pain. Did you know that? Do you know there are guidelines that promote that, non-drug therapies? There are. In fact, we're going to look at the diagnosis and treatment of low back pain, Joint Clinical Practice Guidelines from the American College of Physicians, American Pain Society. That was published in the Annals of Internal Medicine 2007. Well-regarded guidelines. And what do they say? As we're talking, the primary goal of treatment of low back pain isn't analgesia. It's restoration of function with modifications if necessary. Why? Because back pain eventually gets better on its own for the most part. And function is important. But they say in recommendation number 7, for patients who don't improve with self-care, and the self-care there is modification of activities if necessary, heat, over-the-counter analgesics, and Tylenol, we consider the addition of non-pharmacological therapy with proven benefits. And for acute back pain, that's their analysis is acute back pain. Spinal manipulation is a proven method of dealing with acute back pain. I hope I'm making my point that even when we talk about acute pain and acute severe pain, how we treat that pain, whether it's using drugs or non-drugs, isn't necessarily based on intensity or type of pain. It's based on how our particular culture approaches that pain. And that whether it's drugs or non-drugs isn't always about whether it's intense or not. It's a kind of a cultural thing. So what about chronic pain? Well, for a few things we've got to talk about. What makes chronic pain different than acute pain, and one is that we've got to think about chronic pain as not a linear extension of acute pain. So when we take acute pain and apply the same remedies for acute pain to chronic pain, it doesn't work. So chronic pain is not a biomedical problem. It's not something that responds to just a bottom-up approach, and it's not a psychological problem either. That means that we don't have to do anything physical to improve it. But rather, chronic pain, we've got to think about that as a biopsychosocial condition, and it needs both bottom-up and top-down approaches, right? So non-drug and drug approaches. And so that's a multimodal approach, and not a multimodal drug approach, but a multimodal drug and non-drug approach. And the literature is clear on this. I want more proof about this kind of thing. So I looked at the literature. There is a group called the Society for Integrative Oncology, and that was formed in 2003. And again, that was formed by not sort of fringe players, but by the biggest players in the world of cancer treatment: Dana-Farber Cancer Institute, Memorial Sloan Kettering, MD Anderson Center, and the American Cancer Society. And they established a group called the International Society for Integrative Oncology. They made a number of recommendations, which I'm going to go over a few of them with you. Recommendation number 2, all patients, not some patients, not patients that look a certain way, not patients that we think about the advantages and limitations of complementary. By complementary, they mean non-drug therapies, in an open, evidence-based, and patient-centered manner by a qualified professional. Is that interesting to anybody? It's interesting to me. They recommend multimodal treatment recommendations for pain, mood, and quality of life, and they grade them as to evidence. They say mind-body modalities, meaning like mindfulness, meditation, breathing, and yoga, they include in that. High-level recommendation. Support groups and cognitive behavioral therapy, highest recommendation. Massage, 1C recommendation. Exercise with an exercise specialist who's trained in working with cancer patients, high-level recommendation. Acupuncture for pain and nausea, and also for xerostomia or dry mouth, high-level recommendation. Is that the standard of care that we offer patients here? Not necessarily, and please don't take this as any kind of critique of what's done here, but I think these kind of treatments are evolving and there's issues with how to provide them. But things are done, things are moving along, and non-drug treatments are integrated into standard care in many places in a high-level way. And what about chronic low back pain? What do the CPS, APS treatment guidelines say about treatment of chronic back pain? They say in recommendation number 7, for patients who don't improve with self-care, use non-pharmacological therapy with proven benefits. Interdisciplinary rehab, that means a multidisciplinary rehab approach. Supervised exercise therapy, acupuncture, again, massage, again, spinal manipulation, again, CBT, again, and a progressive relaxation. So is that interesting? I think so, because again, the treatment goal is maintenance of function rather than just analgesia. Maybe some people it's just analgesia and then medications alone are okay. But when we're looking also at other treatment goals beyond analgesia, non-drug treatments are very important and validated and pop up in treatment guidelines. So there's other conditions for which we consider non-drug treatments as first-line treatments. Neck pain, there's very good literature for support of chiropractic, acupuncture, massage. Headaches, chiropractic, acupuncture, massage. Osteoarthritis of the knee, a little bit of evidence for acupuncture, but actually emerging evidence for massage. And then other conditions where conventional treatments are not effective, they're unsafe, or not in line with the patient's values, or the pain is difficult to treat. And when I was kind of asking some nursing friends about, well, what should I talk about in this talk? They say, well, make sure you talk about sympathetically mediated pain, because that's something that we have really hard time in the palliative department about. And so, well, I'm going to talk about it. So in my practice, I've always had very good results with acupuncture and sympathetically mediated pain. And this is an older slide, you can tell, calling it RSD rather than complex regional pain syndrome. And you have improvements not just in pain, but in swelling and erythema and hair growth and function of the limb. Sympathetically mediated odd types of pain. Anybody know what this one is? Sometimes I see patients who sort of end of the road conventional medicine with certain odd pain type diseases, and that's called erythromelalgia, which is considered to be a kind of sympathetic vascular trouble. So we can consider non-drug treatments when we've exhausted all our other treatments. Suicide, accidental death, and harm. Can we prevent those kind of things? And can we prevent them? If we're thinking about preventing them and prevention of accidental death, suicide, and harm from the treatment, should we utilize non-drug treatments in those cases? As you know, the point I'm going to make is we should. But let's think about where we can really make a difference. So the one point I'm going to make, and maybe one of the most important points I'm going to make to you tonight, is that pain and comorbid depression is a different kind of pain. And the reason is because it's recognized differently, it's treated differently, it responds differently, and it's different. So When depressed patients present to their primary care provider, with what symptoms do they present? What's the primary symptom? Fatigue? Well, I'll tell you what it doesn't. So generally, the two main questions you want to ask if you're, two main considerations if someone, you want to determine someone's depressed is do they have a depressed mood or they have anhedonia, lack of interest in pleasurable activities, lack of pleasure from life. Actually, how most patients present to their primary care practitioner is not with those situations, but they present more often with physical symptoms, which might be fatigue, might be myalgias, but most frequently is pain. So most depressed patients, when they present to their primary care practitioner, they're going to present not with mood disturbance, but with pain. Do you think all those pain patients are recognized as being depressed? No. And why? Because that presentation interferes with provider recognition of depression. So patients who are depressed and present with pain to their primary care practitioners don't get recognized as depressed, they get recognized as pain. And what happens? They get treated. And what do they get treated with? More often with narcotics. Depressed patients with pain get narcotics more than pain patients without depression. So it's complicated. Now, does depression make pain harder to treat? Yes. Yeah, much harder. And does pain make depression harder to treat? Yeah. Absolutely. Known facts. Do pain and depression share the same biochemical, neuroanatomical pathways? Yes. They're both norepinephrine dependent. And so what would the treatment for pain and comorbid depression be? First thing is you have to recognize it, right? And recognize that some pain will be depression, and that 30 to 50% of chronic pain patients will be depressed, 30 to 50%. But it even goes higher. When you look at patients with facial pain, it's about 85%, the literature says, high. So the treatment really of pain and comorbid depression is to activate descending pain inhibitory pathways. We can do that through non-drug treatments, but we can also do that effectively with drugs. SNRI-type antidepressants like duloxetine, venlafaxine, tricyclics like amitriptyline. So we have to do that because why is it important that we recognize depression? Because it makes our treatment of pain difficult if we don't recognize it. And the second thing is, chronic pain patients, make to you tonight, is that pain and comorbid depression is a different kind of pain. And the reason is because it's recognized differently, it's treated differently, it responds differently, and it's different. So when depressed patients present to their primary care provider, with what symptoms do they present? What's the primary symptom? Fatigue? Well, I'll tell you what it doesn't. So generally, the two main questions you want to ask if you're, two main considerations if someone, you want to determine someone's depressed is do they have a depressed mood or they have anhedonia, lack of interest in pleasurable activities, lack of pleasure from life. Actually, how most patients present to their primary care practitioner is not with those situations, but they present more often with physical symptoms, which might be fatigue, might be myalgias, but most frequently is pain. So most depressed patients, when they present to their primary care practitioner, they're going to present not with mood disturbance, but with pain. Do you think all those pain patients are recognized as being depressed? No. And why? Because that presentation interferes with provider recognition of depression. So patients who are depressed and present with pain to their primary care practitioners don't get recognized as depressed, they get recognized as pain. And what happens? They get treated. And what do they get treated with? More often with narcotics. Depressed patients with pain get narcotics more than pain patients without depression. So it's complicated. Now, does depression make pain harder to treat? Yes. Yeah, much harder. And does pain make depression harder to treat? Yeah. Absolutely. known facts. Do pain and depression share the same biochemical, neuroanatomical pathways? Yes. They're both norepinephrine dependent. And so what would the treatment for pain and comorbid depression be? First thing is you have to recognize it, right? And recognize that some pain will be depression, and that 30 to 50% of chronic pain patients will be depressed. 30 to 50%. But it even goes higher. When you look at patients with facial pain, it's about 85%, the literature says. High. So the treatment really of pain and comorbid depression is to activate descending pain inhibitory pathways. We can do that through non-drug treatments, but we can also do that effectively with drugs. SNRI-type antidepressants like duloxetine, venlafaxine, tricyclics like amitriptyline. So we have to do that because why is it important that we recognize depression? Because it makes our treatment of pain difficult if we don't recognize it. And the second thing is, chronic pain patients have a twice higher risk of a successful suicide, completed suicide, than other patients. And so that's probably from unrecognized depression. So we have to recognize that depression, we have to treat it. And why do we have to treat it? To prevent suicide. So there was a recent article in Pain Medicine, a psychologist named Cheadle suggests when treating this patient population, which is a chronic pain population, the standard of care, not a opinion, should include the routine screening of depression and risk assessment of suicide potential with validated tools. And I asked some of my colleagues who deal with pain and comorbid depression, how do they screen for depression? And they said, well, you can tell, it's kind of a feeling with somebody. We have to get a little bit more, in fact, it supports the opposite, which is hard to recognize depression in pain patients. So validated screening tools for recognition of depression are the BDI and the profile of mood states, and they're recommended by impact group. So what I want you to come away from here is that pain and comorbid depression is something important, something you've got to recognize, and that remember that pain affects provider recognition of depression. So if a person comes in with pain, we're less likely to recognize that they're depressed. Hard to find statistics on people in compensation claims, but in 1999 you have to go back to look for a fellow named Fishbein who said that the risk of suicide in middle-aged white males on compensation claims was 3 times that of the general population. Is it important to recognize depression and screen for depression, chronic pain patients? Yes, absolutely. Treatment of depression and treatment of pain with or without drugs. Well, there's an interesting study, something called the SCAMP trial, published in JAMA by a guy named Kroenke, who's done lots of work on pain and comorbid depression. And what he did was he took patients who were depressed and had pain, and he took one group, gave them standard therapy. He took another, and he optimized their antidepressants, pushed them towards SNRI-type antidepressants. He gave them a stepped self-care management program, and then followed up with telephone follow-ups for a year. And what he found was that that kind of approach gave better results, not only in terms of depression, but in terms of pain. So really, treatment of depression with drugs plus non-drug treatment of pain worked better than standard treatment for either. You might want to consider non-drug therapies as a first-line treatment for pain. What you got to remember, and I'm sure you all know, is that the increased use of opioid pain relievers has caused an explosion in opioid pain reliever deaths. And statistics in the United States are a little bit easier to come by, which is why I use them instead of Canadian, but we could, in some ways, divide by 10 and have a Canadian figure almost. But in 2008, that was 14,800, not due to drug overdose, but prescription drug overdose. And the United States is estimated that 16,000 deaths occur per year due to anti-inflammatory side effects or complications. So those statistics make us think that maybe that's something we want to consider. There might be certain situations we might want to consider non-drug therapies at first-line treatment. I think so. So just to summarize, Non-drug therapies, what we'd look at as top-down treatments, those kind of therapies, acupuncture, massage, chiropractic, mindfulness techniques, yoga, those are proven and accepted as first-line therapy for acute and chronic pain. They're recommended as multimodal options for all patients with cancer pain, and they're effective when combined with norepinephrine active antidepressants in treatment of pain and comorbid depression. And those treatments are very safe. Because we didn't talk about that, death by massage is extremely rare. So, then why don't we use non-drug treatments more often? And so we're going to talk about that. Well, one is awareness, and so I'm trying to do my part to bring awareness about the role of non-drug therapies into consciousness, and I do that at the undergraduate level in medical school. We do that for continuing medical education like we're doing now. We do that at the residency level, teaching about this. And I think you guys are aware now, and you have to kind of think about that. You have to look at the literature. The literature's there, and the literature's strong. Then there's assumptions. And these are all alliterations. So there's assumptions. And we sometimes assume like who might or might not want a drug treatment or non-drug treatment or for what type of pain. We shouldn't assume. We should ask patients. And we should ask patients not in the general sense, like what's important to you. We should ask them specifically, what's important to you? Is it analgesia? Is it function? Is it consciousness? Is it avoidance of side effects? Is it reduced risk of disasters like a suicide, accidental death? What kind of things are important? And I think that's critical to do that as part of a cooperation with our patients. We don't just make those assumptions, but we ask them, we do things together and decide what's the best thing. Maybe more important is availability. And so we talk about acupuncture, massage, those kind of things, and that's great. It's not so great if you live in Dauphin, in which case those things might be a little bit harder to come by. And most of those things cost money, so they're not insured services, and so they cost money. So availability is an issue, but it shouldn't be an issue that makes us just assume that people are not interested in them. We have, like as a Society for Integrative Oncology says, we have to discuss these things with all patients, not just some, and not make assumptions. Affordability, we talked about, part of availability. And then adjudication is when these things, when chronic pain patients become disability patients, doing a lifestyle modification program involving exercise, diet, yoga, group support therapy, low-fat vegetarian diet, that you could reverse coronary artery disease. And he's gotten interest in the United States by insurers. Do you know why in his program? Because it's cheaper than coronary artery bypass grafting. So I think we're going to see the same kind of momentum in pain world, albeit slowly. If you wanted to talk to me about that in my kind of efforts to kind of pull things together. So my whole purpose in doing this talk was to kind of not present one idea is better than another or something that somebody should do or shouldn't do, was to kind of start a dialogue on how to incorporate non-drug therapies with regular care. And part of that involves bridge building.